All right, welcome everyone. Thank you so much for joining us for the second half of our time together today. We're really glad that you're here. I hope you all had a wonderful lunch and we have full bellies and we're ready to settle in for this next stretch. We've had a great day already. Hopefully you were able to enjoy some learnings from our research row rooms earlier and feel empowered and educated and encouraged about all of the awesome things that are coming down the pipeline. I do have a few housekeeping pieces to share with everybody. If you haven't had a chance yet, the Intent out in the main lobby area is open today until 5 p.m. So please, if you haven't had a chance already, head out there, take a chance, go and have a look inside and see what that brings for you. This evening, we have the trip to the aquarium as well. So starting at 4:30, the aquarium table in the foyer will have little goodie and snack bags with a fun aquarium theme. So be sure to stop by there before you take off for that aquarium adventure. Your admission is covered as an attendee of the conference. And with that snack bag, we're gonna hopefully tide you over, but dinner is on your own this evening. As far as transportation to get over there, it's about a 15-minute walk, but I know that it is very warm outside, and if you want, there's also the train that you can take. So if you choose to take the train, that's about 5 minutes, $5 per person, or if you want to walk, that's 15 minutes, and there will be plenty of PPMD team members who can guide you along the way to make sure that you get there. So we look forward to seeing you at the aquarium this evening. So with that, let's take a look at what to expect for this afternoon. So for those of you who don't know me, my name is Rachel. I'm part of the care team at PPMD, and I like to do all things related to clinical care. So it seemed suiting that I would kind of kick us off for the afternoon because we do have a clinical care focused afternoon agenda in store for you each. So we're going to start off with diving into cardiac care, stronger with every beat. Cardiac care is something that's incredibly important to us at PPMD. If you're not familiar with our cardiac initiative, it's something that's incredibly dear to us and something where we are just investing our time and our money and our energy and really rallying around how to advance cardiac care in Duchenne and Becker and for those manifesting carriers as well. So we're really grateful to have a spectacular group of speakers diving into learnings from our recent cardiac care workshops that took place both last year in Charleston and this year in New Orleans, and look forward to the future of what we might expect to see in terms of clinical care advancements. And later this afternoon, we will dive into the ins and outs of GI and GU care. And there is a small modification to that piece of the agenda. Unfortunately, Dr. Dan Wood, the urologist from Colorado Children's, was unable to join us due to travel, so we will have a guest speaker there, Dr. Mayna Scavino, with whom many of you are familiar. So we will pivot, and I think it'll be a really useful panel for each of us. So with that, I do want to introduce Dr. Linda Cripe. Dr. Cripe is a cardiologist at Nationwide Children's Hospital in Columbus, Ohio, and I was lucky to work with her in the clinic for many years prior to joining PPMD. She's been a close friend of the organization for decades at this point, and we're just really lucky to have her. So I will invite Dr. Cripe, as well as the rest of our speakers, up to the panel. And Dr. Cripe, I'll have you introduce each of your panelists, and we look forward to all that you have to speak. Thank you.
Can everybody hear me? Yeah, good. Okay, thank you. Thank you so much. Like Rachel said, I have been involved with PPMD for now decades, it seems, and it's been such a tremendous honor and an incredible journey, and I applaud the organization for all of its efforts in advancing cardiac care. And I am thrilled this afternoon, and we're going to move on pretty quickly because I think I really want you to hear what our panelists have to say. We've come a long way from where we started 2 decades ago with very few cardiologists interested in the care of the heart in this disease to having some of the leading pediatric cardiologists and specialists in the country available to the families now. And I am really thrilled that we have 4 of those individuals here to speak with you this afternoon. We're going to start with Dr. Jon Soslow, who is a pediatric cardiologist at Vanderbilt University, who is going to open our discussion about the heart this afternoon.
Thank you, Linda. Thank you, PPMD, for inviting me to speak. I'm going to see if I can figure this out. Perfect. I have no disclosures relevant to this talk. So what we're going to do is do a brief discussion of the pathophysiology of cardiovascular disease, and then we're going to look at cardiac imaging, electrophysiology, blood biomarkers, and other methods that we will use in surveillance of our patients. And we'll do that in the background of a hypothetical patient, and then we'll briefly discuss how each of these evaluations may modify our care and the strengths and weaknesses of each of them. So, as everybody's aware, when you're born, you have a dystrophin mutation, and you usually have loss of ambulation somewhere in the 11 to 13 year range, and you usually require assisted ventilation around 15 to 18 years. But what's going on with the heart? Well, just like the rest of the body, you have that altered molecular structure and function, but there's normal global function. The heart, to all outward signs, looks normal. And at some point, you progress to cardiomyopathy, manifest dysfunction, dilation eventually. And that definition of cardiomyopathy really varies depending on the person. It could be left ventricular dysfunction, it could be dilation with symptoms, it could just be presence of scar in the heart. What we do know is that the likelihood of that cardiomyopathy increases as you get older, but there's quite a bit of variability in that process. So most patients will have LV dysfunction starting around mid-teenage years, and we define LV dysfunction usually with an LVEF of less than 55%. However, there's quite a bit of variability, and so there's a broad range, and I've seen patients who have LV dysfunction under 10 years of age. I've seen patients in their 20s with normal function, so it really does depend on the person. We also look at late gadolinium enhancement, and so that is the presence of scar or fat in the myocardium. And this usually occurs kind of in the 12 to 13 range, but again, there's quite a bit of variability, with about 15% of patients having late gadolinium enhancement under 10 years of age, and many of the patients I take care of still don't have late gadolinium enhancement in their 20s. So we'll start this, that kind of informs what we're looking for when we see a patient in clinic. And we'll start off with our hypothetical patient at 4 years of age. He's just been diagnosed, and he's referred to the DMD multi-specialty clinic. And we will order vital signs, an EKG, and an echocardiogram. And findings on that visit are normal vitals, a normal EKG, and a normal echo. So what do we order the EKG for? Well, it's part of routine care for us, and we get it in almost every visit. It helps us look at rhythm, it helps us look for fast heartbeats, it helps us a little bit with early signs of dilation or scar. It's a little nonspecific, but we see changes over time. And this allows us to get baseline EKGs before someone may present to the ER or present to another office. And so we frequently like to have a sense of what their EKG looks like so that we can see if there's been any changes when someone presents acutely ill. Echocardiography is pretty much the standard in clinical practice. I'm sure most people here have had an echo or had their child have an echo. It's easy to obtain. We mostly get good image quality, especially in the younger patients, and it's great. You can see there that is the left ventricle in short axis, the circle that's contracting, and we can get really nice pictures and get an idea of function using echocardiography. So the next steps for this patient are really a discussion of expectations. So disease progression, what we're going to do, what we expect in the short term, the midterm, and the long term. And then we start seeing these patients annually, because we do sometimes have a risk of very early onset of disease. All right, so then we're going to skip ahead for a couple years to about 8 to 10 years of age. And at this point, I've likely started prophylactic therapy. I usually start around this age. I usually start with something called lisinopril that is an afterload reducer, so it decreases the blood pressure, decreases the strain on the heart, and blocks one of the hormones in the blood vessels that helps the heart remodel. And in this visit, I'll order vitals and lab work and a cardiac MRI with contrast. And in this case, the blood pressure was normal, the heart rate was fast, around 120s to 140s on the EKG. There was normal lab work and normal function with mild late gadolinium enhancement. So what does all that mean? Well, This is late gadolinium enhancement here where the arrows are. So that bright area, after we give a medicine called gadolinium and then take more pictures by MRI, that shows us areas of either scar or sometimes fat in that region. And we know that scar forms in the heart as part of the process of cardiomyopathy. And in fact, we have some really nice data from Cincinnati from a couple years ago that shows that patients without late gadolinium enhancement had relatively steady function. But then when they hit that red area and they had presence of late gadolinium enhancement, then there was a relatively steady progression of disease. So it really seems like late gadolinium enhancement is the onset of cardiomyopathy, and that LV function declines significantly after you've developed late gadolinium enhancement. We also ordered a Holter on this visit just because of the fast heart rate on EKG. So there are a lot of things that we can get from this Holter. So we can look at average heart rate, and a lot of our patients tend to have relatively fast heart rates. We can look at the minimum and the maximum, and then we can look for any signs of arrhythmia or any signs of here what's listed as ventricular or supraventricular ectopy. And this patient had a relatively normal Holter, but with a fast heart rate. So from a modification of medication regimen, a next step, I would start a Plarinone in this situation. It is a medication that we use that blocks aldosterone, and it's good in our minds to prevent scar formation. And once someone has scar on an MRI, we almost universally start it. It also helps maintain function. And then I would consider a beta blocker. And a lot of us will start it for resting tachycardia. That tachycardia wasn't quite in the range where I'll start it in someone this age, but it'd be something I'd consider. And at this point, I'd transition to visits every 6 months. So we are on 2 meds. We have delayed enhancement. It's someone that I want to keep a little closer eye on. All right, so the next visit, we're going to skip ahead till 17 years of age. And I can tell you that the last echo had abnormal function, but the windows were poor. And so for this visit, we ordered an MRI with contrast, vital signs and EKG and lab work, and a Holter monitor. And the blood pressure is low normal on our meds, which is not uncommon in patients on multiple medications. The EKG showed left ventricular hypertrophy. The cardiac MRI is mildly depressed with significant late gadolinium enhancement. And there's normal lab work. And then the Holter monitor showed a short run of ventricular tachycardia. So, cardiac MRI, the other advantage of MRI in addition to late gadolinium enhancement is image quality. If you look there, just like the cardiomyopathy risk increases with age, our echo windows decrease with age. So we have worse and worse echo windows in general in patients with Duchenne and Becker muscular dystrophy as they get older. And so a lot of times we'll get images like that on the right where you can see that the function is not normal, but you can't do the objective measures that we're used to doing in order to get a good assessment of someone's function. And so because of that, we use MRI, which is not dependent on those windows. And cardiac MRI does have some limitations, so I do want to talk about those. It requires patients to hold their breath. It requires patients to hold very still, or else we get very blurry images. So when we want to do it without anesthesia or sedation, we really need to do it starting around 7 or 8 years of age. Sometimes a little older, depending on the patient and how they are developmentally and how they are from an activity standpoint. So that's kind of the magic area where we really start to do these MRIs. And we tend to get them yearly in Duchenne muscular dystrophy just because we get so much more information from them. We do have some limitations further out. So as patients get older, they might have more problems with discomfort, more problems with contractures, and we can have some difficulty getting them to fit in the scanner. And so in those situations, we can have some trouble, but we can do shorter MRIs in that situation to try to get them in and out quickly. All right, so this is the MRI for this patient, and you can see on the right, that's the same delayed enhancement, just more significant than it was before, marked by those arrows. And on the left, you can see a cine image in the short axis again, and you can see that the area with the most enhancement isn't contracting very well. It's not moving normally, and so that's something that we see as patients progress and they have more scar, then we'll have worse function on the MRI. And then this is a picture of ventricular tachycardia on a Holter monitor. As I said, this patient had 3 short runs of VTach. These are very short, they're a little fast. There's nothing that's going to cause a problem from this specifically, but I worry about this because rhythms like this, even though they're short right now, can be a sign of a risk of long-term having longer runs. And so I worry about having arrhythmias that could cause an arrest or even death. And so I'm going to want to treat this aggressively when I see this on a Holter, and I think most of us would. So what are we doing? What are our next steps? Well, we will likely start or increase a beta blocker for the ventricular tachycardia, because that'll help with that arrhythmia. And then we'll also likely start it anyway because of the dysfunction. So that's usually the time that we start a beta blocker to slow the heart rate down a little bit, decrease the stress and strain on the heart, and kind of our third step, our third med in our guideline-directed therapy. And I'll continue to see this patient every 6 months, but more frequently if there are any rapid changes or any symptoms. All right, so we'll move to our last visit in a 23-year-old now. I'm going to do an MRI without contrast. As I said, contrast is really important for us to look for late gadolinium enhancement, but once we have a lot of enhancement, it becomes less of an important thing. And we're really focused on looking at the function on MRI. And we can do the MRI much more quickly without contrast in about 20 to 25 minutes. And so in this situation, I just want to know what his function is and get an accurate measure since I can't see very well by echo. We'll do vitals and EKG and lab work. And as before, the blood pressure is low on meds. The EKG has LVH with a wide QRS. The MRI is moderate to markedly depressed function, so it's not really where we want it to be. And then there's an elevated NT-proBNP. So this is the cardiac MRI. You can see on the left the short axis, on the right the four-chamber, and the function is pretty depressed. You can also see mitral regurgitation there on the right with the leakage of that valve. And so this patient really, as I said, isn't where we want to be. The NT-proBNP, so this is one of our sort of standard biomarkers that we use for heart failure, but this is the one that seems to work the best in Duchenne. As I said, most of them don't work well early in disease, but later on, NT-proBNP can be quite effective based on a couple studies and associates with mortality. So we know that when the NT-proBNP starts to go up, that we need to be a little more aggressive with our therapies. So in this situation, I'd likely consider starting either Entresto or an SGLT2 inhibitor. These are both newer medicines. Entresto is a combination medicine, sacubitril and losartan. And SGLT2 inhibitors block the sodium glucose transporter. And we don't actually know exactly how they work, but they work really well in cardiomyopathy so far, and we've started to use them more and more in patients with DMD. And then I'd also start aspirin given the significant dysfunction to help prevent any formation of clots. And then I'll continue visits every 6 months, probably more frequently if I start one of those newer meds, just to make sure that it's tolerated well. And again, more frequently with any rapid changes in symptoms. So in conclusion, cardiac assessment really varies depending on the age and the clinical findings. Cardiac MRI is preferred once a patient can undergo it without sedation, and it allows assessment of scar. It is better than echo for functional assessment, especially further on in disease. EKGs can give some clues about changing status and are pretty routinely obtained at visits. And then Holter monitors are good for assessing arrhythmia and resting tachycardia. And with that, I just want to thank everybody at Vanderbilt and in our DMD Cardiac Care Consortium, and thank you.
Thank you, John. That was outstanding. And we're going to hold all our questions till the end, and then you'll have an opportunity to ask questions of all our panelists. The next speaker will be Dr. Chet Villa from Cincinnati Children's Hospital. I've had the good fortune of working with him when I was at Cincinnati Children's Hospital, and I look forward to hearing what he has to say this afternoon. Chet.
So thank you to everyone from PPMD, and thank you to Linda. I think what I'm going to talk today about is kind of how we're moving to kind of use that menu of therapies that you just heard from Dr. Soslow about how to apply it more consistently, and then how to give patients and families a better idea of why we're using these therapies, how to use it. So if they're not at one of the larger centers, or if the recommendations they're getting from their cardiologist are a little bit different, we can kind of have a common language for why we might be doing that. Here you can see my disclosures. I think the first part, again, is a thank you. A lot of the work that we're doing through ACTION is funded by PPMD and wouldn't be possible, I think, without their generous support. And so when we're talking about dystrophinopathy, it's one of the new terms that you've started to see us throw around. Historically, we would say Duchenne or Becker or carrier, and especially from a Duchenne and Becker perspective, with all of the new therapies that are coming to the fore, the old definitions, the black and whites for what would have qualified you for one or the other really don't apply anymore. So you're starting to see us use the terminology dystrophinopathy. That's new for a lot of people, but really we're kind of talking about that kind of whole horizon. The boys who are obviously Becker, obviously Duchenne, and that kind of intermediate in between. The important part from a cardiac perspective is based on everything we know, the therapies don't matter based on your neuromuscular definition. And we should be applying kind of most of these throughout. Now, when you might want to start, it might be a little bit different, and that gets towards what we're talking about in terms of harmonization. Now, why we use the term harmonization instead of protocols is for something like if you're in a clinical trial, there is a protocol. You have to follow X, Y, Z. You have to do this within a 1 week period, this within a 1 week period, this within a 1 week period, and you don't get much wiggle room. In reality, life never works that way. Right? When you have a large population, you know that each one of your boys, or for those of you who are out there who have Duchenne or Becker's, you know you're different than the people you know, the friends you talk to. The way your body may respond to medication may be different. And so as a result, having a protocol doesn't apply. We want general guideline for how you're going to move forward with therapies so you understand why we're on it, but you can't use a protocol in the same way. And that's especially important in today's era, right? There are therapies that are coming out. There's new data that's coming out literally every month. You know, we have a group of cardiologists from different centers around the country that are thinking about this all the time. Keeping up with that data, how to apply it, is actually very hard. And it's exceptionally hard for families because you're not just trying to do it from a cardiac perspective. You're trying to do it from a neuromuscular perspective. You're doing it from a cardiac perspective, from a pulmonary perspective, from a stretching, from a PT, all of these other things. And we're hearing about urology and endocrinology and all of these other things too. And so it's hard to keep up with all of those. And so what we're trying to do is put on paper and in electronic format ways to say, what are the new therapies, what is the best guidance for why we're trying to do that, and how can we move forward? And for those of you who aren't aware, what ACTION is it started as a group of pediatric cardiologists that are treating heart failure. So in people who have congenital heart disease, so they were born with a heart that is not normal, or for people who have cardiomyopathy, that's either acquired or as a result of something like dystrophinopathy, where you're born with a genetic difference that predisposes you to that. And a lot of the same things that we have talked about apply there for cardiomyopathy as a whole. You have all of these new therapies, new ways to apply it. How are we trying to do it? And really the way that we've done it is to try and go about with these harmonized protocols. And we now have more than 35 more broadly within the pediatric cardiomyopathy and heart failure specialty, and we're adding more and more, especially from a dystrophinopathy perspective right now. And why do this? Well, the issue is the existing guidelines that are there from things like the American Heart Association and from Care Considerations can only be done every couple of years. It is quite a bit of work to get all of these people together, review all the literature, put something down that everybody agrees upon, and reviewing all of that literature. The problem is science is moving too fast for that. And we're going to talk about how many of the therapies that we are using today didn't even exist way back when these documents are done. So we have to find a way to continue to update patients, families, and clinicians on how best to do this. The other thing is for many of the trials that tell us what to do, they are not necessarily generalizable. They're not going to be used in the same way. So the people who are enrolling in a trial may look very different. They may look different based on your age, based on your ethnicity, or the type of center that you're in. So we have to figure out how we can apply these therapies outside of a clinical trial protocol in the real world, and that's really where these harmonized protocols are helpful. And then in the end, we'll talk about, I think, why they might be especially helpful for families as well. And so as example, when I gave this talk or a similar talk in 2021, really we were talking about triple therapy for DMD cardiomyopathy. As you heard from Dr. Soslow, really we had 3 therapies there, ACEs and ARBs, which have been around for a long time. So that's your things that end in IL or ARTAN. So enalapril, captopril, lisinopril, or valsartan, losartan, those sorts of things. And they work by slowing scars, relaxing blood vessels. If you have a high blood pressure, they also can help from that perspective. The beta blockers, which slow the heart rate down, decrease your risk of abnormal heart rhythms, and make the heart work less hard, so things like hospitalization when your heart is weak are less likely to happen. And then lastly, those aldosterone antagonists, or MRAs, sometimes you'll hear us say, which slow scarring and interact with the way that the kidney can sometimes respond when your heart function isn't normal. And so we don't want your body to hold on to too much sodium, so it kind of helps in the regards. And that was really kind of state of the art at the time. The existing guidelines at that point, however, did not really have granular things. They would say, hey, you might want to start this at this time. Here's the best data for it. But it turns out that's not especially helpful when you're in a clinic talking to your cardiologist or understanding another part of what we have learned about these therapies, which is dose matters. You get the most of your bang for your buck just by starting these medicines. However, there's an incremental benefit as you go up to what your tolerated dose is. And that's especially important for people who are in their teenage years or adulthood. Your body is changing in many ways. The dose that might be right for you at 13 may be very different for you when you're 18. Or when you're 25, you may not be able to tolerate the same dose because your blood pressure is lower, because your blood vessels are changing. And how do we try and address that in a way that's consistent across centers as much as possible, minimizing variation, but also acknowledging for individual variability. And that was really the focus. So we came up with this guideline, which has very specific recommendations for how we would go about doing it based on the best data available and real world experience with people who are doing this all day, every day. The problem is right after we came out with this, there was a big study that came out of France that made us change that right away. This was a perfect example of why we need something that allows us to rapidly adopt therapies as they come along. And really in that, this was data showing that early initiation of ACE inhibitors before there's systolic dysfunction, before your heart starts to have squeeze abnormalities, pays a long-term benefit. So starting those early decreases your long-term risk of heart failure, hospitalization, and cardiac related issues. And so we had to update that. And then in the interim, we've had now more and more data. So lots of data that Dr. Soslow and his group has generated in terms of how to understand what's happening from an MRI. And then from us, we started to use that justification to go and look at what is actually happening at the heart tissue level, because it didn't quite make sense what we were seeing, what he was seeing, and the old paradigm for what is therapy, which is fibrosis, scar, fibrosis, scar. And then the imaging DMD data was coming out showing that using what we call MR spectroscopy was showing that scar was becoming fat, especially as men get older. And that was especially important when we talk about clinical trials, outcomes, and how we're going to go about making long-term modifications from a cardiomyopathy perspective. So this is a piece of heart muscle from a boy who passed away from complications of COVID. And what you see there in the pink was heart muscle, the way it's supposed to look. That little light pinkish area, the little areas kind of on the higher part of the screen are areas of scar and fibrosis where the muscle is starting to go away, and at the very top in white is actually fat. The heart muscle is gone there. There is no therapy that is going to make a difference because at that point the scar has already progressed enough that heart muscle is gone. That is important when we are talking about early initiation of therapies for things that we think make a difference. But the other thing that is important is we have to talk about this cardiomyopathy in a different way for regulators, for drug companies, and for families. We have started to use, instead of that scar terminology for MRI, fibrofatty change, or LGE, and that's nomenclature that is really important for us to change and for you guys to understand why we want to modify and why we're changing what we're recommending now compared to even 2 years ago. The other part that has really started to come about is, again, understanding what this might mean for rhythm and how we go about in therapies. So here's a man who ended up passing away from heart failure, and what you can see there on your screen right is there is no fibrosis there. The heart muscle is gone. And he grew up in an era where we didn't have many of these therapies. But it's also why we have to talk to regulators about how we have to talk about this cardiomyopathy in a different way. We have to make early interventions when the therapies and the outcomes that they are used to talking about don't happen that way. And I think yesterday's example of where advocacy comes in, I think was really, I think, well taken. This is another situation where we have to make them understand from a science perspective, and I think hearing your guys' voice about why this matters also is important. The other part there is on screen left, which is understanding the risk for arrhythmias. We used to think that this scarring only happened in the lower chambers of the heart. We're now seeing it in the upper chambers of the heart. And in fact, in this tissue here, which you can see is the heart muscle is gone in parts of the upper chamber. That has a different risk profile when it comes to things like arrhythmias, blood clotting that happens up there, or if you were to get an intervention. And that's really important for us to share more broadly so that people can learn how to do this as quickly as possible, whether you live in Minnesota, Ohio, Florida, Texas, anywhere. We need to share this information as quickly as possible with cardiologists, but also with families, so that you know what you should be talking to your cardiologist about if you're not coming to one of our centers that is thinking about this all day, every day. And then the last part really is, so now we went from a triple therapy to what we now consider quadruple therapy, as you heard from Dr. Soslow. So on top of those initial 3 pillars of therapy, we are now talking about SGLT2 inhibitors, so sodium glucose transporters that were developed for diabetes, but we have learned have significant benefits from a cardiomyopathy and heart failure perspective, or for people who have kidney disease independent of that. This is going to be, for many of you, you're starting to hear things about it, it's only going to get bigger. The potential implications for this in Duchenne and Becker's, I think, really is huge. And again, really, it comes back to that last point. Understanding what we now know about the natural history from an MRI perspective, from a tissue perspective, there is a sense of urgency, I think, from our group, from many of the people here, for everybody who is affected by this, and we have to figure out how to do this better. So you heard some of this, and I'll just close the last couple of parts about, again, patient voice, understanding what people need, and then the last part, which is gene therapy. So gene therapy, we think, is a perfect way that we can start to learn and share our experiences very quickly, because as you heard, one of the potential complications for any gene therapy being used is myocarditis, or injury that happens to the heart in a variety of ways, whether it's because of your immune system, whether it's because of the stresses that happen as a result of anything, and how we're going to follow this and learn. The number of patients who have been treated with a variety of different gene therapies is increasing by the day, but the numbers are still relatively small, and the science is still really evolving. And this is a situation where we think harmonization using heart failure cardiologists, electrophysiologists, MRI cardiologists, really to kind of learn and adapt as quickly as we can and to share our experiences is a way that we can get to you guys the best therapies, the best approaches, and understanding outcomes in a timely way. So that will be coming forward with shortly. So that is being led actually by Dr. Nandi, who's going to talk a little bit, and actually the other people here on the stage have all contributed to that document. The last part in terms of a lot of this is what you guys are used to hearing and what you guys gave us feedback for is cutting edge science is terrific, but we don't have access to it, right? It's behind paywalls. It's put in language that you guys even struggle, when I say you guys, I mean us cardiologists, to understand each other. And heck, when a neurologist gets up here and starts talking about some of the things that they're talking about, I have to go back and take pictures and then read. I have no idea what that term was that they used, and this is something where I am doing this all day, every day. And so trying to find a way to convey to you guys what that is. And how we're trying to do that is through interaction with PAC, and feedback on the documents that we're creating. With each one of these harmonization protocols, we are actually trying to create a patient and family-focused electronic version that you guys can use, trying to distill it into ways that make it useful for you, whether it's talking to your internist, family doctor, cardiologist, adult cardiologist, other family members, all those sorts of things. And even one of the stories that kind of drove this was when we were talking to one of the men who gives us some advice about how we're trying to go about doing things. He said, I also need something to explain to my dates why I'm on this medicine, why I'm doing these things, and that kind of brought it home. Each one of us has a whole group of people that support us, and we need to have ways to convey this information to everybody that's important to us and plays a part in our role in our care. Last couple of things, we're going to create some videos. We're doing an additional part about advanced therapies, so what's called I Decide. We're working with a group out of Colorado that has developed patient-focused things for advanced therapies, and we'll also be starting to publish and talk about one of the things which for a long time has been not on the agenda or not been available for many men, which is cardiac transplantation. The evolution of therapies from a neuromuscular perspective, improvements in long-term respiratory care has opened this as a possibility for some, not for everyone. Historically, it used to not even be an option for anyone. And I think as part of the advocacy and you guys pushing us to rethink and readdress some of these issues, we're trying to then, again, become the bullhorn for that further within the field of cardiology. Having other cardiologists start to reconsider these therapies, having adult cardiologists who are not used to this evolving therapy and the evolving outcomes start to reconsider what options are available for people with dystrophinopathy, whether you have Duchenne, whether you have Becker's, or whether you are a carrier. I think that's it. Thank you to everyone, I think, on this stage. Thank you to PPMD. I think much of what we do is really done through a variety of voices and and can't be done by one person. And so thank you all.
And, you know, I think I really loved the quote in your talk, a sense of urgency in a time of hope, and that definitely needs to go on the intent out there. So I don't know if Chet will do that or if one of you can take that on. But, you know, I do want to mention one thing in that the ACTION program that Chet just presented and specifically the DMD arm of ACTION has been supported by PPMD, and it's been critical to moving the understanding of the cardiovascular disease in Duchenne forward. All of the panelists here are involved in that, and it is so essential to us moving forward. So I want to thank PPMD with all our hearts for the support. I realize that when you guys are out there helping raise money through all of the ways that you do that's tough work, but it is so deeply appreciated, and it really is going to make a difference. So I want to thank you. Now we're going to move to Dr. Diepanjan Nandi, who is a current colleague of mine at Nationwide Children's Hospital, who I am thrilled to have on our care team. And I will let his talk speak for itself. So Dr. Nandi.
Thank you, Linda. And just want to say, you know, the five of us up here as cardiologists who live, breathe, and eat everything related to advanced therapies and heart disease. And it's really humbling to come up and give a talk about devices in advanced cardiac care to families who are living this burden every day in a way that I really can't fully ever understand. So thank you to PPMD and thank you to the families for inviting us to talk more about this. So I was asked to talk about taking the scare out of devices, and in particular about ventricular assist devices. Chet and I have literally been called zealots by some parts of the medical community about our wanting to explore the idea of ventricular assist devices in the pediatric and adult community who are afflicted with dystrophinopathies. And I think what I'd just like to say is that we're not zealots for it. I'm not trying to sell anybody on these devices, but what I actually am trying to do is just trying to demystify a little, make sure that families have a little bit of an introduction when possible, so that when we are talking about these scary things, that there's perhaps a little bit less fear, so that we can have a good conversation with those providers who are able to think about these things. In reality, what I'd like to do is talk and yell at other physicians to not be scared of these devices, but to think about them in the context of our patients. I have no relevant financial disclosures to this talk. So, of course, what we're talking about, again, are ventricular assist devices. So we can do all of the things that my colleagues up here have spoken about with our preventative medicines and with our treatment oral heart failures, and we haven't even somewhat discussed some of these IV or intravenous medications that can help the heart continue to squeeze well. But when all of that goes wrong, because it can, no matter our best hopes and desires, we're stuck with hearts that don't pump well. In particular, what we're talking about is the left ventricle, which is the pump that pumps most of the blood, all of the blood to your body, and it pumps it out naturally via the aorta, which is the big blood vessel that comes out of the top of the heart and supplies the body with all of the fuel and blood that it needs. When it's failing, we can provide for some patients something called a ventricular assist device. The device we use now is called a HeartMate 3, and that device lives inside the body. In particular, this HeartMate 3, you can see it sits in the bottom of the heart. It's called the apex of the left ventricle, and it is essentially a big fan. That fan spins fast enough to draw blood out from that non-functioning ventricle and then push it out that long graft, so it bypasses the heart and goes out directly to that ascending aorta. It can run continuously and has run for long periods of time for many patients. Now, it is open heart surgery, and there are many parts to it, and we'll get into that. This is just another schematic of it, so you can sort of see all the fancy engineering. This is the best device that we've ever had the pleasure of working with. In fact, it's the only implantable device on the market right now, and it's been used safely in thousands and thousands of other adults, but very few muscular dystrophy patients thus far. The device is basically over-engineered. That fan that spins is sitting on top of magnets that keep it centered, and the magnets also keep it spinning to reduce the amount of moving parts in there, which makes the device overall safer. It's made out of surgical-grade titanium, and it has all sorts of great special safety features to it to make it even safer. Here's just another animation of how that blood gets by suction drawn into that fan blade, which is also called an impeller, and that then pushes it out that graft that goes out towards the aorta. The device is fully implanted inside the body. That's the HeartMate 3 itself, which is that shiny metal object plus the graft out to the aorta. What comes out of the body are this pump cable, because it needs to run on electricity. And so what's tunneled out of the body is that pump cable, which then connects to a different cable called a modular cable, which then connects to this box that people carry around. It's called the system controller, and it just allows you to look at how the device is running. And then that system controller is connected to usually batteries or a different power source. These batteries last between 7 and 12 hours, depending on their use. And we give patients 8 of them and a charger for the batteries. We give patients a mobile power unit, which is just something that can plug into the wall when you're asleep or safely at home. And with the many batteries, our patients are able to be out and about and trying to do and live their lives. I have 2 patients that were gracious enough to send me some fresh pictures so I could sort of show you what this device looks like, and this is what you see. So these are 2 patients with dystrophinopathies, one who was implanted about 5 years ago and one who was implanted about 6 months ago. And you can see where the drive line comes out. That's got a little bit of dressing. Both are dressed slightly differently based on their ages out and how they prefer to do it. There's also tools to sort of keep those extra drive cables in a nice stable position so they're not flopping about and moving. And the care of this is very, very important. Here's sort of just a zoom in of how that device, how the cable comes out of the body and is affixed to the body so it just stays out of the way and isn't in getting in any problems. This patient is intermittently ambulatory and has it, the bag that's connected, that's hanging off the back of his intermittent use wheelchair. And both these patients out and about. The patient on the left has their cable connected to their bag, which they keep on the back of their power chair. Both these patients report high qualities of life and are doing the things they want to do, and would not be alive without these devices. Now, I'm trying to take the scare out, but as I said, I'm not a zealot and I'm not a salesman. And any conversation about open heart surgery and devices going inside your chest needs a real conversation about risks, and there are a lot of them. There are risks that every patient shares, and then there are some risks that are particularly part of patients with dystrophinopathies. So bleeding is a risk, of course, with any cardiac surgery. However, we are always needing to be on blood thinners for these patients, for these devices rather, so that we can avoid clots. Any clot that were to develop within the system would by definition be shot out to the aorta. And if it goes to the aorta, that can cause strokes and head to the kidneys or other vital organs. However, this is the safest device we've ever been able to use. The overall stroke rate is well less than 10% or 5% in general, and in our pediatric population with ventricular assist devices, it's even lower for well-used such devices. Wound healing can be a particular issue. Patients who come to us with very poor nutritional statuses, it's a big surgery and you have to heal from it, and with very little muscle mass on board, that can be very problematic. People do ask us commonly about the use of steroids and wound healing. We have not found it to be an issue where steroids, even high-dose daily steroids, have been a problem to use these devices, but they can certainly weaken the bone, and that can make it a little more difficult. Respiratory function. Respiratory function, I'll talk a little more in detail, but we have to be intubated for such a big procedure, and being really careful about how to get patients extubated and quickly back to their baseline breathing mechanisms and modes is very important. This is data that Dr. Villa shared from 3 VADs that were done at Cincinnati, and so this is looking at is their FVC, or functional vital capacity % predicted, at pre-implant, around their time of implant, and then years out from implant. And you can see so many patients have an immediate hit to their FVC, their respiratory status, but then that does improve over time with the device. There are other risks, infections. So that driveline site, that is a really careful thing that has to be taken meticulous care of. Once you get infection of that driveline site, that can ascend up to the device. And once the device itself is infected, that can be very problematic. And the only thing we can do if it becomes unable to be treated with antibiotics and the like is remove the device, which in many cases would be fatal. Skeletal muscle strength is also very important to discuss, but we know that any shock to the system of inflammation or otherwise from big surgeries can reduce muscle strength, but it needs a lot of careful consideration with our neuromuscular colleagues when we talk about said devices. The other ventricle, the right ventricle, the one we don't talk about as much, that can become a problem in many of these patients as well, and of course the other organs can become problems too. So we have to think about all of these things. But what happens when we do this? So ACTION has been trying to look at this more carefully, specifically at muscular dystrophy patients and specifically at dystrophinopathy patients. And so we published this earlier this year and last year, looking at all of the ventricular assist devices we'd placed within ACTION centers from 2012 through 2020. This in our registry members, that was 18 VADs, of which 12 were in dystrophinopathy patients. There were 4 deaths, and I can't get around that. There were 4 deaths eventually. However, there was a long time between those deaths. So many of these patients did well for several years, out to more than 4 years. 2 patients, this device was used as a bridge to transplant. And as Dr. Villa mentioned, this is something that we're increasingly suggesting. And there are currently 6 patients who were well on the device at the time that we finished this analysis in 2020, out towards several years, on the average of 1.5 to 2 years out. I myself, as I mentioned, have one patient who's out 5 years. There's another patient I know of who is more than 10 years out and doing well on device. So are you still scared? Of course you are. You can't be. You can't be fully saying, oh, everyone, I want to sign up for this. This is a incredibly individualized decision between patients, families, and teams. We have to have really frank conversations about these. We can't shy away from them. And it is really a community that we're trying to create, families and caregivers working, and patients and physicians working together to pick the right patients and the right times. Remembering that we have these opportunities in good patients to do ventricular assist devices means we have to preserve the opportunity to do so, which means preserving respiratory strength, preserving neuromuscle strength when possible, being on the right therapies to keep our hearts as happy as they can be, to avoid other renal complications, bone health complications, nutritional complications that may prohibit us from being able to move forward with the ventricular assist device. Because as we know, if we do it in the wrong patient, we can have the bad outcome we don't want to have. But again, the point of this talk is supposedly to take away the scare, and I probably scared more of you than not. But the real idea is we want to demystify the process, give patients that early ideas about what may be possible for the correctly picked patient to get them the best outcome that they can. I'm a firm believer that the right patients can do really, really, really great with these devices and have a significant improvement to their quality of life and longevity of life. Thanks again to Parent Project Muscular Dystrophy Action and my colleagues up here as well. Thank you.
Thank you, Deep. And our last speaker before we open this up to questions will be Dr. Ryan Butts, who is currently, I don't know if he's a Dallas native, but he's currently working at UT Southwestern here in Dallas and must have some unique genetic mutations to tolerate this heat. I'm really impressed. So we welcome Dr. Butts to this podium.
No genetic mutations, just a lot of AC. And I just want to thank everybody for the great talks you've heard. Now you guys are stuck with me. So I'll try to not, unfortunately, disappoint, but nonetheless. So we're going to talk a little bit about transitioning. And we're going to try to boil this down to maybe 3 steps, which there are a ton of little steps in between. But before we really get into it, I have no disclosures. I am not an expert on transitioning. Everything I've learned was really and truly by mistakes that I've made or watching other people do a lot better. This is exactly how my wife says I learn in our marriage, but nonetheless, we'll go and move along. But really want to discuss a little bit today about the roles and responsibilities, not only within the medical team, but also within the patient and family, and how we can make this process go as smoothly as possible, albeit it never goes as perfectly as we would like. I already mentioned my disclosure, sorry. So first of all, a little bit about putting this in a little bit of context perspective. This is a problem that is led by success. Through a lot of great work by our neurologist and pulmonologist colleagues, and through the work that Deep and Chet are doing with ACTION, patients with muscular dystrophy are living longer, and each decade outcomes are getting better. So we're having to have more and more patients transition from pediatric care to adult care. So this is a great problem that we have created. But also, as these Kaplan-Meier curves show, this time of transition, when the patients are going from the age of being considered a child to adulthood, is also a critical period where a lot of morbidity and mortality can occur. So we're asking patients to move from one group of medical providers to a different group of medical providers right at a very critical time period. So as you can imagine, this is a lot of stress. So let's get into some steps and maybe how we can make this happen. Before we get into steps, every single place always needs a key to success. Ours in Dallas is actually quite simple. Nelia Soares is our nurse practitioner who's in the audience, who's embarrassed right now because her picture is up. She is incredibly hardworking, sticks through this process of getting patients ready to be transitioned, getting them up to the adult center, making sure that things work out. And you really need somebody like Nelia who's got that sort of bulldog mentality that just won't give up in order to make it work well. So what's, and this really, I'll mention Nelia. Melia is in the middle. The pediatric team is often the sort of the go-between, the source that starts with the pediatric with the patient and family, and they're looking to the pediatric team, whether it be a group of cardiologists, neurologists, pulmonologists, whatever specialty. I'm going to talk mainly about cardiology because that's what I know. But they're the sort of the go-between. They're the ones who are going to help make that first initial contact between the patient and family and the future adult team. So step one, plan early. What's too early? Probably never too early, right? I mean, sometimes as early as 13 and 14 to start talking about what transition is going to look like. Why start that early? Well, I think there's a lot of important questions to start in the early phase. From a patient and family standpoint, ask who. Who should I go see? Who should I, when I leave this, right? Because I'll be honest with you, there is a million adult cardiologists, private practice, academic centers, you're left and right, and not all adult cardiologists are necessarily going to be invested in taking care of patients with muscular dystrophy as others and have the same background. So asking that question, who do you think I'm going to go see in the future? Just even having that name sometimes relieves a ton of anxiety. Oh, I'm going to see so-and-so. You can Google them, you can Facebook stalk them, Instagram, all that sort of good stuff, whatever you want to do. But it does get rid of that anxiety and you start to know. Because you're going to ask then insurance, right? Lovely topic, right? But unfortunately, a lot of insurance that's taken by pediatric providers may or may not be taken by adult providers. And these are things that can actually be addressed early. You may have options, you may not, but if you can actually make those transitions and having conversations with financial counselors early on in the period, because it takes forever to fill out the paperwork to move that insurance, and you hate to do it when your appointment is supposed to come up in a month. Also questions about guardianship, depending on the patient and each one. Maybe this is appropriate, maybe this not, but how do you go about the process of establishing guardianship? What are the adult providers going to want in order to prove that you have guardianship? How do they want it documented? How are they going to record it in their system? So these are all questions. I'll ask a lot of questions. You shouldn't expect answers right away, to be totally honest with you. Because sometimes more questions just lead to more and more questions, but eventually you get there. And this is why you probably should start early. From the medical team, what are we supposed to do when we're talking about planning early? Well, we should answer that who question, right? We should identify adult provider or providers. I will be honest with you, here in Dallas, we had it really quite easy. We got really, really lucky a while back with Dr. Maman, who did an excellent job. We could make it transition really easily. But sometimes when you have only one provider and that person leaves, like we've experienced, it becomes a lot harder. And you start trying to identify more and more providers who could, and maybe develop a team. Great that Chet was talking earlier about harmonizing clinical protocols. I think this is incredibly important for the adult and the pediatric providers to actually talk about, hey, this is how I'm taking care of my patients. How are you taking care of your patients? Some of it is there areas that are different that aren't necessarily needed to be different, and you can harmonize it, and that just makes that transition a lot easier on the family and the patients, and so they know what to expect. And then standardized transitions. So understanding a little bit about how you're going to transition and when you're going to transition. For instance, for us in Dallas, what we really started talking about is for the patients who start maybe around age 18 or a little bit earlier, who start developing ventricular dysfunction, that we may actually transition them a little bit earlier in case they do end up progressing to a VAD, as Deep has just mentioned. But they do that and they actually have established care with their adult cardiologist prior to going to VAD. So it's not, hey, by the way, we got this 21-year-old who needs to come over and see you because they're 21 years of age, but by the way, they're probably need to go to VAD in 3 months. That's a lot for a family to take on. So a lot of times we try to individualize it, but talk about it and develop it and develop agreements between the pediatric and adult team. Step 2, discuss regularly. So why should we, so you talk about these things, you answer these initials, start planning early, but don't give up. That shouldn't be where the conversation stops. This is often how most of us want to feel about it. I mean, this is how I feel about it as a pediatric provider. I don't want to talk about it. you're my patient, you don't get to leave, you know, that's probably how a lot of parents feel. I like you, you know, I like my provider, I feel very comfortable. Why do we have to talk about change? Nobody really wants to talk about it. Because you sort of feel like this, right? We're on this nice tightrope, we're talking, we've figured out the balance, we've figured out how things work, and oh man, we're talking about cutting that rope off. Just doesn't feel right, does it? But so why should we talk about it? Well, I think it's obvious. We should talk about it because our plans change a good bit. How and what's going on with a patient at age 13 to 14 is not what's going to be going on with them at 16 to 17. Their plans change. They're going to go to college. Maybe where they're going to go, are they going to stay there all year long? Maybe they need a new adult provider who's not local to their parents, but local to their college. Maybe their health condition has changed. Something. So we got to talk about it and bring it up again every once in a while. Maybe it doesn't have to be an in-depth conversation, but it does need to occur. And small changes can make a big difference as we're going through all this sort of stuff. So maybe there's changes in medications. You've heard a lot earlier about the harmonization of whether or not we're starting to use Entresto, SGLT2 inhibitors. Well, there are a lot of adult providers who adopted some of these medications earlier, and so maybe we need to start talking about that. Also, what are some of these small changes that we can anticipate, such as maybe as pediatric providers, our protocol is MRI every other year. The adult provider is MRI every year. Well, that sounds like not a big deal to most of the providers probably in the room, but for parents, that is going to be a big change. And that just talking about it so we can anticipate it is important. And then I think all in the end, this is really about trying to set up the expectation and reality and reduce that gap, because that's where frustration comes in, right? The parent has one expectation of what their life is going to look like as when they go to the adult provider versus the true reality is something different. And when that exact gap exists, it makes it a lot harder and it makes it a lot easier to get frustrated and want to go back to what you knew before. The last step 3 is a launch. It's a one term, but really I would think about it more as a process. This is a nice little diagram that NASA puts out about what a launch entails. So it's not just one time. It's not just that, hi, it was nice to see you at this visit, next visit with your adult cardiologist, and that's the end. It shouldn't be that. It should be a true process. So from a medical team, what do we need to do? Well, we need to provide our adult colleagues with a concise and accurate summary. So both terms up here are incredibly important. I think plenty of you whether providers or parents have looked through your child's chart. You see a lot of words that just are repeated over and over and over again and probably don't mean much, and I'm very much guilty of this. So a lot of the stuff that's in there is not necessarily accurate, but neither is it concise. When it has too much information that's not necessarily relevant, it's not going to have the impact on and provide the information that's needed. So I think it's incredibly important. Now this can exist whether it be a transfer note, progress note. I think that's up to each individual institution to figure it out. Talking between the pediatric and adult providers about what information is best transmitted and how to get it there can be incredibly individualized on the institution. From a parent perspective or the patient perspective, consider a visit. I think us as pediatric providers have a tendency to sort of describe adult providers as if, to use my Star Wars reference, as the dark side, right? It's a Death Star. You're going to walk up, there's going to be Darth Vader sitting behind the counter who's going to just ask you in this really ugly tone, what do you want? Why are you here? That sort of stuff. And it's not really the case. But consider a visit. Go check it out. And when I say consider a visit, that means a visit without the clinic visit. So it's just go find out where the clinic is. Figure out how to drive there. Figure out how maybe your child or the patient is dependent on a wheelchair for ambulation or other assistance, and how are you going to navigate that? So take away a little bit of that anxiety. What does parking look like? I know those all things sound small, but when you're adding on that anxiety plus the anxiety of having to go talk to a new provider, it all adds up. So hey, take a little bit of piece of that off it and go visit, and you may actually get rid of that stress of having to figure out about what the provider is going to tell you, but you get to meet people, and it's a little bit more enjoyable experience, and it makes your first provider visit seem a heck of a lot better. And then sweat the details. Small things matter. So talking in good detail with that first. What is it going to look like? Again, what are the exact medication doses that we're going to? What are we going to do? What meds are going to ask for? How is it going to look like when they get our first cardiac MRI? Asking these small things, trying to figure out as much as you can so that you have the confidence and knowledge going into the first visit. So in summary, remember to plan early, discuss regularly, and then eventually you got to make the launch. Just remember, honestly, perfection is not possible. So don't think that you're going to, anybody at any time during this transition, it's going to go smoothly. There are going to be hiccups. There are going to be things that don't go well, and you should just accept that. To be totally honest with you, and work through it. Because if you get frustrated, if you expect perfection, you're going to set yourself up for failure. You're not alone. Look around here. Every single parent in here and provider is going through the same experience. So the anxiety that you are feeling, the nervousness, the feeling of you walking into this great unknown void, you're not the only person. So feel free. You should rely on your fellow, whether it be your fellow providers for us, or whether it be other parents who are going through the same process. Please reach out and share your experience. And then in the end, while you're going through this, remind it's in the end, it's actually a good problem. If you're going through the process of transition, that means that the patient or your child is actually growing up, getting older like they're supposed to, and then in the end, it's a good thing. So we'll move along, and thank you. And again, I'll throw it up Nelia's face up again, because she is really and truly the one who does all the work, and I am a complete imposter up here standing giving this talk. Thanks.
And now I think we have time for some questions. And do we have somebody who's passing the mic? There's stand-up mics off to the sides. If you could go to the mics if you have a question. You know, and while people are getting to those mics, I want to maybe start off the panel with the question that I think, I know as I've circulated amongst the attendees of the conference, is the question I get asked most frequently is, what do we need to worry about, and what types of things do we need to think about in the context of gene therapy with regards to the heart? I know that's a big question, but I think probably the one on most people's minds at the moment. So I don't know if one of you guys want to jump in on that one. Is the mics on, guys?
Okay, yeah. Hi, I'm a
wait, hang
Karen.
on. Just pause just 2 seconds while we answer this question
sorry.
and jump in.
Can you guys hear me now? Yes. Okay. Just to answer Dr. Cripe's question regarding gene therapy in the heart. And to be honest, I think everyone right now, we're in a data gathering phase. The clinical trial and the approval of the Sarepta product we're very excited about as a hopeful way to really improve muscle function across the whole body. And we're really not sure about the heart quite yet, about the functional improvement we're going to have with that, long term especially. We do know there's a lot about the potential for myocarditis, as Dr. Villa mentioned earlier. What we're providing, we're writing this harmonization through ACTION that we'll be putting out probably in the next few weeks about ways to carefully monitor for myocarditis, as well as give some general guidelines to programs about how to keep a close eye on the heart and to successfully treat through potential myocarditis. It is true, to be fair, we have not seen huge amounts of myocarditis, certainly with the Sarepta product, And there's a lot of conversations about other products and other things that are in trial currently, but we really are still on the early phases of that. So we'll sort of another part to mention is, of course, that the ACTION registry that we're doing that's looking at hearts in general, we are collecting patient data for anybody who has received a gene therapy who comes to an ACTION participating site, and we'll hopefully be able to get that data together and really get a better sense of the heart risks as well as hopefully the heart benefits down the road. Thank you.
All right, question.
Thank you. You kind of answered part of my question because I was thinking the microdystrophin will turn DMD into BMD, and Becker muscular dystrophy patient does tend to have more cardiomyopathies than the DMD patient. So I have another question is for carriers. As for me, I'm from Dallas local. For my son, he was seen at Children's House Dallas. And after Dr. Mammon left, it is hard for the carrier to find any cardiologist to see. I actually did a telehouse with Dr. Mammon. He referred me to UT Southwestern back in March. I still haven't heard back from UT Southwestern, and I've been reached out a few times. Last time I was told was Dr. Rush will come back and contact me, but nobody from the clinic ever contacted me back. Thank you.
Well, Dr. Butts, would you like to take that question?
I think I have a feeling that was directed at me.
Sorry.
You know, absolutely. No, I feel your pain, to be honest with you, because on the pediatric side, we were ridiculously lucky to have Pradeep as part of the team and being able to transition similar to Nelia, having somebody that was so passionate but be on the adult side. I will be, to be completely honest with you, I have spoken with our adult colleagues and Pradeep's former boss about the importance of actually identifying a cardiologist within their group who's willing, and it's still in process, to be totally honest with you, and I think actually they're going to advertise and hopefully bring somebody into the group. I agree. It really, the experience that we've had here in Dallas really highlights the need for us as pediatric cardiologists to almost continue to push our adult cardiology colleagues into this field and bring up the level of care that we're providing, but honestly, helping our patients transition. So I wish I could give you a much more straightforward and easy answer as in, sure, call this number and we'll get you an appointment right away. But I don't have one right now, and in the end, it highlights the difficult infrastructure that is providing care.
Oh, okay, thank you.
Sorry, I'm very eager to ask my question, so it's very hard. I'm right here. I don't have a voice, so I sound very dumb right now.
We're having a hard time hearing you. Can you talk into the mic?
Yes. Anyways, can you introduce yourselves by your name so I can ask the specific question to who I want to? Just, never mind. Okay. I'll try not to take that long, but nobody else has any questions. I just wanted to help anybody else. So, number one, I'm a carrier, and I thought this was going to be more focused to that, but my son's also 2.5, so he'll have to deal with this as well. And I'm just wondering, what age do they have to start seeing a cardiologist to begin with? So
your question is, you're a carrier, and you're wondering at what point do you need to start seeing a cardiologist?
No, I have a carrier. I have a cardiologist appointment set up. I'm wondering for my child. He's only 2.5. But when do you start going to see a cardiologist and pursuing that?
Okay.
I mean, from our standpoint, we would start to see you now.
Okay.
At least at Vanderbilt, most of the time people get referred into our DMD multi-specialty clinic. In all honesty, a 2.5-year-old, I might see you every 1.5 to 2 years in the beginning until you're about 4 or 5, or your son's about 4 or 5, excuse me. But because I think it's a very low risk, but I'd like to get people plugged in as soon as they're diagnosed. So we have seen kids younger than 2.5.
Okay, awesome.
And I think it's important there because we can also talk to you about how we approach care. Most of us up here do it very similarly, but not exactly the same. And so at that first visit, I will spend time actually going through, and what your cardiologist should do is go through what the outcomes are right now, how they approach therapy, how they approach diagnostic testing so you know what kind of things that you're going to be getting moving forward, and kind of where things are going forward. I think that first visit actually matters quite a bit, not because of risks of cardiac disease, but so that you can get a feel for who your cardiologist is. And in some places you may have a couple of different options for a cardiologist. And to me, it's like any other relationship. It's not just about their brain, it's about the way that you work with them, because they may be the smartest person in the world, but they may not be the right fit for you. So that first visit matters for all of those reasons, even if I can say, I have never seen a boy who's 2 years old have cardiac disease.
Okay. I have more questions, but I can just see you after because I don't want to stand here the whole time. Unless anybody else wants to go, can I ask more questions?
We do have a question from the chat. So maybe ask your question and then we'll move on to the next question from the chat.
I would be here a very long time. I will just speak with them after. Thank you.
Sure. All right. So if anybody else has questions, great. We've got somebody at the mic. But let's go to our online viewer. We do have somebody.
Hang on 2 seconds. We got one person right there, and then we'll go. Do you want to?
Sure.
Okay. What you got?
Okay, so first of all, I apologize. I'm from Kansas, and we got Dr. Mammon, and I feel so sorry for all of you people.
Yeah, we're talking afterwards. And not pretty words. Just kidding.
Anyway, thank you for that. My question is, I have an adult son, a 28-year-old, and while I recognize the problems with using echoes for these guys, it's also, like you said, very hard to get an MRI of them because they can't typically lay down without having, excuse me, some breathing support. They're not very comfortable. So if you're not getting good echo images and you can't really get a decent MRI, are some of the markers that you guys are talking about fairly predictive as far as outcomes, or what else should we be looking at?
Yeah, that's a great question and something that we grapple with a lot, unfortunately. So the first thing I will say is that we try to do really quick MRIs in patients who can go in for maybe 20 minutes, get a functional assessment. We do them in young men on CPAP and in young men with trachs, and so we've certainly done that multiple times. But even that can be kind of a big deal, and our patients don't really love it. Our techs don't really love it, to be honest. We need an RT or multiple RTs to get that taken care of. We don't do this at Vanderbilt, but if a protocol that should be up and running soon, we can do where we will be able to do a contrasted echo. And that is, I would say, probably not quite as good as an MRI, but it's better than just a regular echo because you can give contrast and you can see the walls a little more easily. It does involve placing an IV, which can be difficult in some of the older young men, but that's an option. And then for now in clinical care, NT-proBNP is the other thing that we use pretty frequently. And so as I said, it does work. It's more for later in disease, but I've certainly seen where we get mild elevations, and it can kind of give us a sense of things might be changing. And so we use that pretty frequently in older boys and young men. And I've talked to some of my adult colleagues who use that pretty frequently as well. And then our long-term goal is to have better ways to test for this. And so we have studies looking at other biomarkers that might be helpful for getting a sense of where patients are and where they might be going. But I think from a clinical standpoint, it's those others right now.
And I think there are also some important things that are very individualized there, because I have a number of men who are in their late 20s and 30s who we actually talk about whether we really need to get that additional imaging, depending on where their heart function is and how often they want to come in to fit with their life goals. We will modify that. Depending on where your heart function is, we don't always necessarily need to get it every single visit. In fact, for a lot of it, it may be about symptom assessment, clinical assessment, and echo doesn't matter as much either because the images are not great, or because of where your function is already, there's not a lot of additional prognostic benefit. And what matters more are what your labs look like and how you feel. And for a lot of older guys, that is what we end up doing. And I think this is really important because we hammer so much on imaging and the importance of imaging, especially early on when it's hard to discern symptoms and some of the other stuff, that some of the families actually feel like because they're not doing it, because they're not pushing, there's some guilt there. And I think it's a very different thing when you're older and you have longitudinal assessment and a broader discussion about where all of that fits into how his heart's doing, because it's a very different discussion as a 28-year-old than it is as a 13-year-old. And a lot of family struggles with that guilt, and I think you can get very good care that doesn't always have to be imaging focused or MRI focused.
Thanks. I would also like to say, for those of us with older guys that are relying on adult cardiologists, that the introduction of that fourth drug is new to them, and their kind of minds are blown when you take somebody like Dr. Mom and take his advice back to your adult cardiologist. They're kind of like, what? This is not, we don't know anything about this. So, you guys, I know you guys are working on written things to help us take to those other cardiologists, but just want to encourage that.
Thank you. Because I think your comment is really important, and we're working on it. And PPMD is helping us do that.
That was effectively the same question that we actually had from our online viewers, so that was perfect.
I think the other one, to go back to the carrier point, is actually a big deal. A lot of women that we see put every moment into their sons, into their family, and they don't always pay attention to themselves. And we are seeing more and more men who are older, and as a result, women who are older. And I think it's a reminder to say, I think it's important for you to be able to do all of the things that you want as mothers, as grandmothers, to make sure your health care is taken care of, because I think there are a lot of women who put themselves secondary in a lot of ways. And we are only starting to understand more and more now what the cardiac implications are for this. And so I think it is extraordinarily important. And I think so much so that next year the cardiac meeting we're going to have is going to focus on adult care and especially carrier care, because it is it's a big issue. You guys are all trying to do the best you can for your family, but I think sometimes you have to pay attention a little bit, because we may have therapies, and just like for the boys, getting started early may pay dividends, and it may also explain why you may feel tired, where you may feel these other things, and I think we're building a group of cardiologists and adult cardiologists who can help.
Yeah, and I think it is frustrating for me to say to a family, and families are engaged. They say, I want to see an adult cardiologist, and so I send them to an adult cardiologist, and they only come back to say, well, my adult cardiologist, like you were saying, stared at me and said, I don't understand this disease. And so that makes me feel bad. And I think it is an onus on the community as well as the providers to really try to change this, and to appreciate the fact that you may need to be a warrior in this fight as well. To say, no, there is specific and unique needs for an adult carrier, and call my provider, call my son's cardiologist, call my daughter's cardiologist, and help me work with you, because you're in my community, to improve care. And so I will employ you all, in addition to joining us, to be engaged in that fight. Do you have an additional question?
Yes. So what he just said sounds exactly like me. I'm finally starting to focus on my own health. I got an antidepressant, so it's changed my whole life. It's done a 180, and I'm sad to be here, but I'm glad to hear the advice. So I'm really happy with everything that you've said, and all the questions I relate to. So I don't want to take the whole time. If y'all need to go, I would just appreciate contact numbers, and I have my own doctors I need to ask, but it's nice to have other lifelines. So I have other questions, but I have ADHD, so I'm very overwhelmed, and I can't process this right now, like to say what I want to say. Maybe if you have a little bit of time after, but yeah, I guess.
Thanks so much for your comment. I'm not sure if you guys can hear me, but I think this is a really important thing for the PPMD has been helping us try to arrange when families have more questions. And Rachel Schrader here leads the patient care part of PPMD and is a great resource to help connect you with more resources as we get there.
I know you're very busy cardiologist. I did want to say that I appreciate that you went to college for the rest of us. I think I can stand here and say that we all appreciate you very much, because I am too overwhelmed to ever go to college with all of this, with everything I have going on. I have my own success out of college, so it means a lot that you help all of our boys. Like, sincerely, thank you so much. It means so much.
I think we all feel that. I think we all feel that gratitude for you all.
Well, thank you very much, and we appreciate that. You know, I think it's a partnership, right? I mean, I think that the only way this disease changes is if everybody here who is from industry, who's from clinical care, who is from families, and the patients themselves, you know, advocate in Washington, D.C., advocate at all levels, and help with the fundraising, because it does take money, and the money that is raised does make a difference. And I think PPMD, I am very proud to be involved with this organization, because I have always seen them be good stewardships of all of the hard work that you have been engaged in with regards to funding and raising monies. I think the efforts directed towards ACTION are spot on. That's a network of cardiologists in this country who are well networked and well resourced to help answer some of these questions. And so, you know, each year that we come back, or each meeting that we come back, I hope we can report to you that changes have been made. And I think that we can do that today. You know, when I sat here 20 years ago, it was just and there were a couple others, but you know, it was a very lonely panel, and now I'm sitting with the world's experts here, and it was only it's baby steps, and each baby step makes a difference. So thank you. We appreciate what you said, and your tears do not go unnoticed. So thank you.
All right, thank you so much, everybody. This was a really, really wonderful session with some spectacular speakers. We're just so lucky to have had each of you share a little bit of your afternoon and your knowledge and wisdom with us. So with that, we're going to go ahead and wrap this session. We have about a 30-minute break in the schedule, so go out, grab, snack, drink, water, potty, and we will be back here at 4 o'clock for our GI and Nutrition GU panel. So we will see you all at 4 p.m. All right, thanks.